Well, hello, and welcome to another episode of Care Decoded. We are beginning a two-part series today discussing one of the most talked about issues in healthcare, and that is CMS's new focus on RADV audits. My name is Mark McKeown, and I'm Vice President of Sales and Business Development with InfoScience, and I'm very pleased to welcome my guest via phone, Colleen Gianatasio. Colleen and I have known each other for much longer than we'd like to admit, both being deeply involved in the risk adjustment world. But Colleen is well known as an expert in the areas of risk adjustment, coding training, and value-based care. So Colleen, welcome and hello.
Thanks, Mark. I'm so delighted to be here.
Well, listen, this is a really, really big topic, and I really appreciate you joining us for this, but let's get right into it, if you don't mind. So, first thing is, CMS seems to be changing their audit approach. So the first question is, what does every plan every year really mean to the industry, and what's that impact going to be, do you feel?
Well, Medicare Advantage is under quite a microscope right now. And CMS has made it very clear that they're taking their duty to ensure that plans are billing the government accurately for the coverage that they provide to Medicare patients very seriously. So for those of you who have not heard, CMS will audit all eligible Medicare Advantage contracts for each payment year in all newly initiated audits. On top of that, they've promised to invest additional resources to expedite the completion of audits for payment years 2018 through 2024. So what that means for the industry is, like you said, we've been doing this for a long time, and for a long time, the sentiment was that CMS was only looking at the big players, right? And that mid-sized and small plans could kind of fly underneath that radar. It's simply not true anymore. And we've seen that not only through this increased CMS scrutiny, but the OIG and DOJ activity that we're hearing about almost on a weekly basis. Every plan is going to have to plan for the resources needed to pass a RADV, and that could be quite a substantial investment. They need to ensure that risk adjustment compliance efforts are an embedded part of their organization. I can't state that enough, and I'm going to repeat it. Risk adjustment compliance efforts need to be embedded as part of our organization. I'm going to take it a step further because I love to frame my approach to risk adjustment around people, process, and technology, and it really works here too as we prepare for this increased RADV activity. It's people, process, and technology. So we'll start with number one, people. We need to dedicate the resources to ensure consistent and ongoing coding education, auditing, and provider engagement. Second, we have to look at our processes and ensure that our workflows are updated to meet the challenges of this new value-based environment that we're in. And lastly, and probably most importantly, we need to look at our technology. Let's look at our EMRs, but going beyond that, we're entering into this exciting and sometimes even intimidating new world of AI. In my opinion, how plans embrace and utilize new solutions in this space is going to dictate how they'll succeed or fail. The best solutions are flanked by skilled business of healthcare professionals on both sides. Careful considerations need to be given to how organizations are implementing the proper internal controls and monitoring systems for these solutions.
Colleen, that's great. That's great. That's a great overview. One question that you did bring up is between RADV and this value-based care type of environment. Why do you feel that RADV risk is growing now at the same time that value-based care is expanding?
I think it's for a number of reasons, but the biggest one is we've been shifting from fee-for-service to value-based care for quite a while. And I feel like in recent years, many organizations are trying to play catch-up, and in my opinion, trying to do too much at one time. This has led to some serious missteps in a lot of cases. And OIG's ongoing audits of high-risk diagnoses tell us exactly where we've gone wrong as an industry. They've made some significant findings, and there's a huge cause for concern here. When I look at being successful in value-based care and in RADV, I focus on three main elements. I focus on creating a culture of compliance, reducing provider abrasion, and telling the patient's story.
That's awesome. I think we all in the healthcare industry can certainly appreciate all three of the impact of those, especially around provider abrasion. just from the day-to-day processes we put them through, certainly to a RADV audit and responding to that. So speaking of that, what are some of the most common misunderstandings about RADV that you've heard from both providers as well as plan leaders?
From a provider perspective, I think the biggest misunderstanding is underestimating the impact that a failed RADV can have. Providers really need to know what's on the line if a RADV has failed. For plans, I think many of them, especially those ones who have not had a RADV yet, they don't realize how much work goes into a RADV. Once it's kicked off, it can't be done by just one team. It takes a lot of partnership and collaboration throughout the organization.
Well, that's a great segue into this is a great overview. So now let's get a little more tactical about this. So how do you feel organizations should be thinking about RADV in the context of a broader risk adjustment strategy?
So I've been working in risk adjustment for quite a few years, and I have developed what I like to call a SWAT team type of approach. And that's where we pull everybody together proactively before you're chosen for a RADV. And that means before a RADV happens, you're going to pull key team members together. And those team members can be contracting, right? Contracting is going to put some language in on releasing records needed in a RADV, and that it's an urgent request and that they need to be turned over in a prompt fashion. Because if we can't get the records in a RADV, it's automatically failed. We can't support that diagnosis code. As part of this SWAT team approach, you also need to pull in your communications team. There should be a very comprehensive document that is ready to go when a RADV happens that explains the importance of it and the very short timeline. But this communication should happen throughout the year as well, so that providers are aware of it, and it's not the first time that they're hearing it when they get the request for the review of records. Provider engagement or provider relations, depending on where you work, should be communicating throughout this process. You should have a designated medical director or a clinician that is the point person to have clinician to clinician discussions. So if a provider group is perhaps not responding to a medical record request, or they don't see why RADV is important, sometimes that clinician to clinician conversation is just priceless. And then of course, legal if needed. Pull your legal department in if needed. But really pulling this SWAT team together before you get the notice that you're getting a RADV is important, so that everybody knows their role and how they're going to respond when the process starts. I also want to give a serious reminder here. Extrapolation begins with payment year 2018, which is your 2017 dates of service. And I want you to all pause right now and think about where your programs were in 2017. Ask yourself what policies were in place, what vendors you were using, was there accurate oversight to your processes and procedures? In most cases, programs have developed a lot since 2017. So going back and really knowing where your risk areas are is an important exercise while we get ready for this new scrutiny.
That's a really good point. I know I've talked to a lot of payers, and one of their issues is going back this far are finding the providers that are either still practicing or in some cases are still alive. And so how do you get records from practices that may have closed? So that type of thing. So that's a real good way to start. One of the things that systems are usually looking for, or auditors say they're looking for in a chart review process, are many different things, but a lot of conversation has come up around making sure that the documentation meets the MEAT standard. Why is that so critical for plans, and is that different from the prospect of a provider?
That's a great question, and this is a subject I could talk about for quite a while. I'll try to keep it short. MEAT is an acronym that's used often to train coders when they're learning risk adjustment. It stands for monitor, evaluate, assess, or treat. And when we're teaching coders to use the MEAT standard, they're really looking for evidence in the record that a diagnosis is supported and that it can be accurately submitted on a claim. It's a great tool. I used it myself when I first began in risk adjustment. I've taught it to many coders. Want to just be really careful here, though. When we're talking to coders, we use meet criteria. When I talk to providers, I don't talk to providers about coding. I talk to them about accurately documenting the severity of illness of their patient. So I use the acronym DSP, and that stands for Diagnosis, Status, and Plan. And the reason I change the way I speak, depending on my audience, is because providers don't think like coders do. They're thinking clinically. So if they can come up with a definitive diagnosis, a status, is that diagnosis stable, worsening, or improving? And the plan, how am I going to treat it? Am I going to send them out to a specialist? Am I going to put them on a medication? You're getting the same results. The documentation is going to support the diagnosis, but it's important that we speak accurately depending on our audience. And both DSP and MEET support the ICD-10 guideline, which is what OIG, CMS, and all other auditors are looking for in risk adjustment. And that's to make sure that the diagnoses for chronic conditions being submitted are impacting care, treatment, or management at the encounter. That's straight from the ICD-10 guidelines.
That's awesome. What a great way of looking at it. And thank you for sharing the difference between those two. And the two audiences are different. As we talk to payers on one side, or coders on one side, and providers on the others, providers will strictly tell you, I'm a clinician, I'm not a coder, and almost refuse to learn coding. So we all have challenges going forward that. So I think that's a great way to differentiate between the two. Moving a little further along, what do you feel are some of the most common pitfalls that cause coding to fail validation?
I've reviewed a lot of medical records in my time, and I've seen almost every coding issue there is. I'm going to boil it down to three of the most high volume. The first one is bringing diagnoses down with no support. Sometimes providers learn a little bit about risk adjustment. They understand that it's important that these diagnoses go out and they're reported for risk adjustment, but they don't understand that the documentation has to support it in that encounter. So the first one is assessment diagnoses with no support, or even worse, importing the entire problem list into the assessment and thinking that that's enough for risk assessment purposes. The second one would be some old school bad habits that have been around in risk adjustment for quite a few years. And I call them blanket statements, right? So it's for every diagnosis, the provider realizes, oh, I need something else besides just the diagnosis. So I need to put something in there so that the code can be picked up. And they use very vague terms like continue current therapy or followed by, and they name another type of provider. Well, that's not really telling us how that encounter was impacted by this diagnosis. So blanket statements would be the number two pitfall. And lastly, providers not being educated on ICD-10 rules. I know it's probably not a top priority for a clinician, but it's really important for them to know how the great clinical care and the patient care that they provide is translated into codes that drive their reimbursement and their quality scores.
Those are all great points, and thank you. I want to refocus just a little bit now and start talking about not so much systems or players, but putting together the compliance piece, putting that playbook together. I know back a number of years ago, we used to talk about mock audits, and most were afraid, and most consultants said, don't do it because you have to report what you find. Now you almost have to do something along those lines to find out what kind of exposure you may be up against. So how can plans and provider groups perform mock audits to find and fix issues, preferably before CMS does?
Great question. This is really an area you have to be careful about because there is truth to what you find in a mock audit has to be reported. So it really pulls in the 60-day overpayment rule and returning incorrect payments. So if you look under every single rock, whatever you find under there, you have to return the payment if there's an overpayment made, and you have to correct the problem at its source. So I caution organizations to really be thoughtful on their approach. know your organization and know your network. We've all worked for large, if you've worked on the health plan side, you know your network, right? There's providers who really get it. They've got updated EMRs and they're doing great. There's other providers who might even still be on paper. You have to pick and choose where you're going to look. You would know your weak points. Look for your major outliers, just like in any type of audit, and know where your own organization's weak areas are. And then to eliminate some of this work, because I know we're all dealing with very strapped resources, if you will, use data analytics and your system configuration teams to help your risk adjustment and your RADV teams to eliminate what I call the noise. There's certain rules and certain diagnosis codes that you don't need human eyes looking at in these, if you call it a mock audit or, a RADV prep audit, whatever the case may be. But there's certain codes that are very easy to set up from a system configuration standpoint that you don't have to use your valuable human resources for. Things like strokes, right? Strokes don't occur in the outpatient setting. So it's easy to set up configuration that says, if you see that diagnosis code with place of service 11, which is the outpatient office, we're going to stop that. We know that's wrong every single time. Another coding rule that's very explicit and an easy one to configure in your systems is for acute myocardial infarctions. ICD-10 guidelines tell us very specifically that acute code can only be used within a 4-week period. So if you work with your configuration team, you can think about the clinical presence of an acute myocardial infarction. That patient or that member is going to be an inpatient in the hospital or at least in the ER. So you would use your configuration to look at those places of service around these codes and stop those codes before the payment is sent out.
That's really great. That's really great. Thanks. We will get into much more detail in section or in number 2 of our series, but just to touch on it for a minute, what role should regular provider training play in this audit readiness piece?
As much as I hate to admit it, while I'm passionate about coding and documentation, it's not a top priority for our providers. The providers are focusing on patient care. So what I found successful is making sure that providers hear the message through each step of their employment. We've implemented some programs at past organizations where, as part of their onboarding, providers are hearing about the importance of RADV audit readiness. Going beyond onboarding, have this conversation as part of your standing meeting agenda items, and even think about including micro learnings where they get a 5 to 10 minute pre-recorded education that they can listen to in their downtime. I'd also recommend sharing real life documentation examples. Oftentimes when we're educating a group of providers, they all think when we go over insufficient documentation or documentation that needs to be improved, I think the common response from a provider, if they think it's the clinician next to them that they're talking to, they all think their documentation is perfect. So using their own example to show them what they're doing right and what they're doing wrong has been really effective for me in the past. And the last tip that I'll share here is get your EMR team involved in these discussions. It's going to be really valuable for you as an organization to know where your provider's pain points are, but it also allows your EMR team to know where corrections need to be made.
Good point. Good point. Thank you for that. One kind of touchy question right now, and that's with CMS expanding its audit pool and most especially using extrapolation as a penalty against that. How do you see internal processes need to adapt to that type of change?
Yeah, that's a really touchy topic. Like I said before with the SWAT team approach, we need everyone involved, from contracting to medical directors to legal. I also think we need to start changing the way we do risk adjustment report out. Historically, it's always been, okay, here's what, the revenue we made for the month, and maybe perhaps the revenue that is still left on the table. But going forward, risk adjustment report outs really need the balance between revenue earned and balance that with your RADV mitigation efforts. So RADV mitigation includes your deletes, right? As we're reviewing chart and we find things that should not have been paid, we should be deleting those. And it does result in money being taken back, which is a pain point, especially when you have to report that to your CFO. But balancing that message with protection from extrapolation is a huge shift, and that should be started right away. So yes, we brought in this amount of revenue, we had to delete this amount, but it protects us from extrapolation, and that equals X amount of dollars. My biggest tip in this area is to invest in education, provide routine feedback on both overcoding and undercoding, and make an investment in auditing. Make it part of the everyday conversation.
That's some very, very good information. I know for a long time with risk adjustment, it used to be something you did just before sweeps came out. Now we finally got the industry into that is a real daily operation that they look at. And I believe that probably this RADV audit and compliance and accurate coding is going to have the same type of ongoing everyday type of operational impact that probably it should have had all the way along. In an effort to try, now that we got through a little of the technical discussion, in an effort to try to look at what the industry is doing, I'd like to look at kind of leveraging some of the technologies for these compliance kind of offerings. How do you think AI, since that is both a good word and a bad word, depending upon who you're talking to, but how do you feel that AI-powered coding assists in helping identify unsupporting documents before they go out the door?
I think there's a lot of power and a lot of benefits from AI. And I know, like I said before, it can be scary and intimidating. And if not implemented correctly, it can be very problematic. But the power of AI in this context is taking the burden of having to focus on coding away from a provider. Providers want to focus on clinical care. So if we can put the AI in place, we can allow the provider to focus on patient care. It does the work for the provider that they don't have time for, right? Whether that's bringing a combination code forward that they wouldn't be aware of, or an additional code that needs to be coded based on the documentation. ICD-10 coding rules are really complex, and coding guidance is always being updated. So AI, if implemented correctly, can help providers stay on top of these changes without having to give it a lot of thought.
Awesome, good. And while one final question is, while I don't necessarily want to talk about specific ROIs, but what do you feel is the return on investing in prospective review tools versus relying on retrospective cleanup?
So retro can only take you so far. It's a really costly exercise when you think about it, because it requires chart retrieval in some cases, and it doesn't allow you to focus on getting it right at the point of care. When you bring your risk adjustment efforts up to the point of care, you're changing provider behavior and you're eliminating a lot of the administrative costs. Retro also doesn't allow you to provide timely feedback like prospective solutions do. It also eliminates the need for claims adjustments or payment takebacks, which are often very difficult, if not impossible, to get that money back in its entirety. Another important reminder: it's crucial to find problems early, as OIG has also made it clear that we're expected to find where an issue begins and correct it, not just fix it and move forward. And I think that's a message that a lot of people haven't heard yet, but it's not simply good enough to fix the problem and move forward. They really want you to correct it at the root and go back and do whatever corrections are needed.
Wow, Colleen, thanks. And I think that's an excellent point for us in Series 1. I want to thank you for the overview and tactical approach for RADV audits and for compliance coding and what the industry needs to be looking for doing this. We'd like to invite everybody to the next episode, where we'll be talking about the provider role in RADV success and how the partnership between payer and provider can best solve RADV issues. So Colleen, thank you again for joining us, and thank you everyone. We hope to see you next time.